far to our knowledge, only affects 1% of all Fanconis. So what we just heard now affects us all, and now we are switching heavily gears to a very special complication of the disease that we really need to address carefully in the future. So I'm stressed out to present you some very, very new things, new findings, new observations. And I will go through these very first slides very quickly, but I would like to get you in the position of a physician. And it's the challenge of the concepts of health and disease. So, for a very, very long time, we haven't known what we know now. And we thought about, or my colleagues back in those years thought that diseases occur due to misbalance in the fluids of the four humors. And I mean, like, they based on this understanding also their treatment. It's important how you define disease. You also put the treatment on here. And this only changed, this understanding, due to technical developments. When the microscope was discovered or invented, people have been able to discover bacteria as the source for diarrhea and not the misbalance of fluids. It took us a very long time to use this knowledge of the bacteria to treatment. And as you know, the discovery of penicillin was just a chance. It came by chance. It was not heavily studied, but it wasn't just a lucky situation. And of course, there's this wonderful date of the 28th of February where we have the molecular transition. Now we know what causes Fanconi anemia. And we are just now in the first days of the clinical trials that might really be beneficial for the hematopoietic complication of the disease by using this knowledge in gene therapy trials. So why I'm showing this slide? It is really important to understand the disease in the absolutely correct way to get the right treatment. And this is challenging. And I would like to stress out why it's important for all of you to come together and to be connected with FARF, and why the FARF registry or any other registry in the world is so hugely important, because we are still in the process of learning. We do not know everything. So the concepts of and the characterization of the disease is really essential for the really right treatment. Or you can put it in other words. And this is a sentence that you have to keep in your brain. Yeah? The understanding of the disease like Fanconi anemia is really important to find effective treatments and even preventives. And we heard yesterday a lot about cancer, now we hear a lot about nutrition. And I think nutrition really is important because it directly influences how our genes are working. So, and therefore it's really important to understand this. And in 2014, this whole story about what we call now FANS, Fanconi-Associated Neurological Syndrome, began by a poster at the FARF Symposium where I presented two cases from Germany where I had no clue what's going on in these two patients. And then there was a huge gap for me as a treating physician. I had many different challenges in that time, but then new patients came to the field with the same problem, and in 2020, at one of the FARF Symposium, we had a whole session focusing on that, and what was really the game changer in the field was one of the first FARF meetings in 2021, during COVID, when we had a very intense discussion, when really big projects have been established, where we discussed ideas and characterizations. And so what I want to present now is the status quo. And what is true today could be wrong in the next year or in 10 years. But what I will present you now is what we really focused on. It is the characteristics of the FANS. And this is very important. It is the characteristics divided into three parts. It's the clinical characterization, or the characteristics the radiological features, and what you see under the microscope, the histopathological characterizations. To put it in other words, FANS is not something that summarizes any neurological symptom in Fanconi anemia. It has clear characteristics that the experts have agreed on, and I would like to present you today these characteristics. Some of the characteristics are easy to understand, some maybe are a little bit challenging. So first of all, starting of course with the patient. Patients with FANS always present with an acute aspect of the disease and later on with a chronic symptomatic aspect. The acute phase is really challenging for the families but also for us as physicians because it is an acute loss of neurological capabilities. Either they have a central nerve frequency paralysis, or they cannot walk, or they cannot pee anymore. So it's an acute presentation. It is not a symptom that is slowly increasing, but it's really from one day to the other, like as you have switched on the light. And unfortunately, most of the times it's hard to explain why we have this symptom. And on the chronic phases, I mean, like this sentence is really difficult for me to say, but this is what we observe now over more than 10 years. If you ever have lost a neurological function, it's really hard to gain this function back again. So once you have lost the function, it is probably that you will never get it back again. So I said that the acute loss of neurological functions is the first aspect of the disease. So these are some of the characteristics that we have seen in Fanconi anemia patients, and I want to point out to the most frequent ones. So I already said the central fascial nerve palsy is a very frequent observed feature, also hemiplegia or a seizure. Sometimes it is also a very weak limb, weakness of the limb, and it's really interesting that it's mostly really the lower limbs. So this may improve, but these are the features that you may have, and the 50% of all the patients also have visual abnormalities. And what is this? This is an impaired vision, and the impaired vision is really difficult to characterize clinically, but we can characterize it very easily when we look into the eyes, into the retina. The retina is the back part of the eye, and we see that there are signs that the veins are like, normally they are really straight and they are really tortuosity, so they make really big curves, and this is not normal for the veins in the retina. And what is the basis of this is what you can see, or what we can see is that these vessels are damaged and that they show leakage. So there's a little bit of bleeding in the retina, and there's a technology called fluorescent angiography where you can really detect these little tiny lesions where the bleeding occurs. So for this part of the disease we have quite a robust treatment. It is laser therapy, and it can really control the leakage nicely, so that patients, when they say, okay, I have this visual impairment now, and they go for laser therapy, one can stabilize the disease. But I also have to say that we have 2 individuals who lost completely their vision, unfortunately. So this was the clinical characteristics. Now I move over to the radiological features, and this is of course difficult because you are not experts in reading slides. So I will explain to you what you see here now is the brain, and it's like cutting the brain like this, and the nose is up here, so we are looking to the brain from the feet to the top. So here's the front and here's the back, and you see this very big white area here. So this is an edema, so it's swelling. So the original lesion is this black thing and these little dots here and there, what you can see. And there is also what we have just discussed for the retina, bleeding. And you see it can also occur with more little lesions, and these are seen here and here, there, or here in the brainstem. So these cuttings are from here to there. And there's something in the brain that is called gray matter, and this is like these things here around. This is the gray matter. This is where the cells are sitting, and the white matter is where the cells have their arms and their legs. So all lesions are only located in this white matter area and in the brainstem. And very frequently we see this also in the cerebellum. So this is the little brain that controls how we move. So also therefore we see a lot of clinical features in the movement impairment. And you see also here it's the same appearance that these little white areas we find in the cerebellum. The MRI is very good to detect tissue damage. We also can make CT scans. CT scans is not good for a good characterization of the tissue, but for calcifications. So therefore the CT scan is very important to classify the bones. So what you can see here in the CT scan of the same patient where I showed you the MRI pictures from, that you also have these dots. So and this is what the also here in the brainstem, and this is what the radiologist says when I see something that is in the MRI and on the CT scan. This is calcification, and the only thing or the only reason why we know calcification in the brain occurs is old bleeding that is tried to somehow be repaired. And you see this bleeding or these white spots and this calcification also here in the brainstem and also in the cerebellum. So putting together in the acute phase of the disease, where patients present with this acute symptom, we very frequently see this massive lesion that I showed you in the beginning with the edema, so like the swelling. And on the follow-up, we have these little dots, the calcification. They always stay stable because, I mean, the calcification, it does not go away, but all the bigger lesions, they can also disappear. When we look onto not the radiological features, but also on the pathological slides, this is the brain from the same patient that I showed you on the MRI and the CT scan. And you can see very easily, so this is the gray matter area and this is the white matter area. So you see all over here are these little dots. And this is a very important information as well. When looking at the brain in reality, the disease was much more severe than we saw on the imaging technology. And this is something that we discussed yesterday when we discussed about screening. How good is MRI, how good is CT scan? So when we look really at the brain, we see the same things, but it's really more severe than we thought. And this is especially true for the brainstem. You see here the calcification all over the brainstem. And under the microscope, it's really the question, the calcification, where is the calcification sitting? And this is now, again, a very difficult slide for you because you are not used to that. But I show you here, we have the vessels, the little vessels in the brain. So you see here the vessels again. And these vessels do not look normal. Normally, the vessel should be just one ring. But you see here, the ring is surrounded by a very thick red area. And here you can see it even better, this here or here. And you see in the surrounding area of this vessel, you see a lot of these dark spots, and these are immune cells. When we did some characterization of the immune cells, these immune cells are not for inflammation, these cells are for repairment. So that our immune system is also very important for tissue repair. So when you cut yourself, all what you see in the surgery are immune cells invading the tissue to repair the cut. And these are also the same cells that we see here to repair this whatever area we have here to do the repairment. What you also see here is these red areas. So this is the bleeding. So yes, the calcification comes from bleeding. And unfortunately, what you can imagine, what happens when a vessel is blocked, when a vessel cannot put the right energy, give the right energy to the tissue, what happens is that the tissue around is to die. This is also something what we recognized on this histopathological features, that around the small vessels we see a lot of demyelination, so that means that the nervous cells, so that the arms of the nervous cells are going to die, and there's a lot of, this is a special staining, calcification that you see really is a lot in that area. So summarizing these pathological features, we see a problem with the little vessels, and we call it microvasculopathy. So the little vessels in the brain have the problem surrounded by the calcification. We see that the vessel wall is much thicker than normally, and that this might lead to the demyelination of the nervous cells, and then we have these focal bleeding signs. And the hypothesis of this feature is that this is a disease where we have a blockage of small vessels, and this is a chronic thing, so maybe the vessel is blocked, but you don't have a direct symptom, but the symptom comes later on when immune cells are invading to do the tissue repair. So this is the hypothesis for right now. I would like to show you some demographics of patients from Germany whom I am aware of. Unfortunately, we have now 2 more patients coming to this list, so I present the last 10 patients we have. And I would like to put your draw your attention on one thing. So, in Germany, all of our patients with FANS have been transplanted. Of course, we are aware of one patient in the States who is not transplanted, but for the time being, it seems that this is a problem maybe of transplanted Fanconi patients, or maybe transplantation accelerates what maybe some other Fanconi patients also might develop. Next thing, very important, all of these 10 patients have the radiological features that I just presented you. These radiological features are very specific, and the radiologist who knows about FANS can pick that up very easily. However, we have 4 patients in the series without any neurological symptom, meaning they have no neurological impairment. So this patient here only has retina problems, so like vision problems, but no neurological impairment in terms of walking or other things. And this patient, you could even discuss, is this FANS at all? Because the only thing what we have, this female had an MRI for whatever other reason, and we found the exactly same radiological features of FANS in her, but she did not have any symptoms in the retina and also no neurological signs. So I would say this person does not have FANS because she has not clinical symptoms. The disease is characterized by clinical aspects, radiological aspects, and pathological aspects. Really important. And then we have other patients where we have only, again, the retina involvement, and they are for quite a long time stable, like this patient here, one acute episode, but then stable disease since 17 years without any treatment. So the variety of the patient is really huge. I want to summarize the characteristics. Again, we have the acute presentation. Every single Fanconi patient with FANS presents acute. It's an acute problem. Then the regain of neurological function is a problem. The retina always has to be checked. The radiological characteristics are absolutely clearly. You have in the acute situation a massive lesion with the edema. The edema can be very well controlled by steroids, but you have to taper down the steroids as quick as possible. And on follow-up, you have these characteristics of the calcification in the very special areas of the brain. and when you look under the microscope, the pathologist would see things that he has never seen before. So it's really the small vessel blockage with the surrounding edema, the infiltration of the tissue repairing immune cells, and the bleeding. So, this is my last slide. I have some take-home message. We defined the clinical pathological characteristics of a very, very new and absolutely new disease. Not only in Fanconi anemia new, there is no comparison. There is another disease where we might have similar aspects. So we are now trying to find out if this is also the same on the pathological background. But those patients have other gene mutations that are not involved in the Fanconi patients. So we try to find out if the pathways are in the same manner involved or not. But it is really important that FARF, due to the Sparks meeting, made us to put really clear characteristics of what we can call FANS and what not. FANS is super rare. It is, for the time being, only affecting 1% of all Fanconi patients we are aware of. So everyone has to deal with nutrition, everyone has to deal, however, with cancer and screening for cancer, but FANS, for the time being, not everyone has to deal with. It is a disease of the small vessels, and it's not an inflammation of the brain tissue, like, for example, multiple sclerosis. For now, I would not recommend at all screening for FANS, and this is also going back to yesterday. When do you want to make a screening, or when is the screening only feasible? First of all, it is really important to have to know the disease. Now I'm only presenting you the characteristics, the definition of the disease. We are far away of knowing the disease. Second, the screening must be really good, so that you can also apply a treatment, and we are far away of knowing what treatment applies to patients affected with FANS. So for the time being, the screening for FANS, meaning putting the patient in the MRI, makes no sense at all. It might make sense in the future when we understood the disease better. And it is absolutely crucial that we need more biological material. I just showed you that what we have non-invasively, like with the imaging, is not enough to understand the disease. We need more biological material to characterize the disease better and to find maybe models, because also our animal models for Fanconi anemia do not present these problems. For the time being, treatment, unfortunately, is still experimental. And this is not only true for one patient compared to the other, it is also true for the patient in himself. I said to you that I have treated or seen my first patients, or presented my first patients at the FARF symposium in 2014. The first patient presented in 2012. And this patient was in really many treatments, but none of the treatments was in a way that we can see, now this was working. Maybe sometimes the treatment was working for 2 years, and we thought it was working, but then after 2 years the patient stopped the medication and things were stable again, but then we restarted the treatment and the treatment did not do anything. So it is really important also to have in mind what might work now for one patient, might not work for another patient, and even might not work for the same patient maybe 5 years later. So it is because we haven't understood the disease. It is still experimental, and unfortunately it is really try and error. So last sentence, keep calm. It is not for everyone. It is important that we really characterize clinical information, biological information of this disease carefully in a structured way to understand the disease better, and very important, treat with caution. And I'm happy to take any questions.